We're going to talk about treatment for the endodontic periodontal case. We're going to talk about the options that include both endodontic and or periodontal treatment, root amputation, hemisection, bicuspidization, and of course, extraction. What are the indications and etiology that could include the various options we have? Well, they're endodontic in nature, they can be periodontal in nature, restorative in nature, or a combination of all of these elements. Considering the endodontic indications, we have broken instruments that can't be retrieved, root perforations, and also blocked canals that could be blocked either through treatment, through ledging, or any number of other reasons, including debris in the canal. Some periodontal indications would be non-treatable furcation infections, disease localized to one root, and there's a number of others. Restorative indications would be iatrogenic in nature, a retreatment that involves removing this post and repairing a perforation that may have occurred, filling the canal. So there's any number of things that we can do to try and retain a tooth other than just removing it and putting in an implant. And there's also combination etiology. You can see in this case here that there is a very large post, overly large for this tooth. Radiographically it appears that this tooth has a fracture. There may or may not be some failed endodontic treatment or at least recurrence of the infection. But this also may have occurred because of the fracture, new bacteria introduced into the system. The concept of doing a hemisection, splitting a tooth in half, or root amputation, it's usually done in molars, and of course it depends on where the furcation is found in the molar. When you have a clinical situation like this with a furcation close to crestal ridge, then it's favorable for any of these procedures. When you have a furcation that's low, you have the potential of having a vertical defect. Similarly, in these photographs, when you have a furcation that is close to the alveolar ridge, this is more favorable than a situation where the furcation is much lower. This can result in vertical defects, as well as this example, which you see the line where the bone might be. This is very favorable, less, and this is not favorable at all. And if you're considering doing a root amputation or a hemisection or any procedure along those lines. A little tip that if you anticipate splitting a tooth in half, then you could take a silver point, you could take some gutta percha, and just put it through the furcation to identify where the middle of that tooth is. It'll make cutting that tooth a bit easier. In a study that was published in 1983, they were looking at hemisected molars. Failures were primarily endodontic in origin was their conclusion. I'm going to disagree and say that the failures were primarily restorative. I don't know if this is the best indication for this type of procedure. Again, in 1983, implants weren't as predictable as they are today, and this is something that would normally be attempted on a frequent basis. However, I just don't feel that the restorative follow-up on this is appropriate. In a treatment that was done by Dr. Patrick Batista, faculty member at the School of Dental Medicine, at the request of the periodontal department, they were going to do a root amputation and they needed the endodontic treatment done first. This tooth was endodontically normal. Dr. Batista was going to do the procedure because a root amputation was going to be performed. These are the pre-treatment radiographs, tooth number 14. We prefer taking two pre-treatment views to give you an idea of what the anatomy is. Additionally, today we have the benefit of taking CBCT radiographs to give us even more information about the anatomy and the morphology of the tooth that's going to be treated. These are treatment and working films, and this is the post-op, and you can see that there's an MB1 and an MB2. Both were treated and both were over-prepped, put amalgam in the canal. And the purpose for the amalgam is to avoid the necessity of doing a retrofilling procedure after the root amputation is completed. Another reason for completely treating the canals instead of just leaving them and over-prepping them and putting the amalgam is you don't always know when the procedure is going to be done. Has been the occasion that when the tissue has been reflected that the Periodontists might change their mind in terms of which canal is going to be amputated. So it's more predictable and better to treat all the canals in a tooth even if a hemisection or root amputation is contemplated. So here are the endodontic records, a pre-op, the post-operative, again multiple views to assess how the case was obturated. And this is the post-amputation. You can see that the root is gone and the amalgam remains as a seal. Another situation that is somewhat usual, we see it every once in a while, where you have periodontal disease around one root. This tooth is vital. They're contemplating doing a root amputation here. The endodontic treatment is done. The tooth is over-prepped occlusally and amalgam is placed. And this is the post-treatment, and you can see that the root is gone. And this needs to be left self-cleansing for the patient to maintain periodontal health in this case. Another situation where this restoration has contributed to the formation of plaque on the root. There is periodontal disease one root, and again the treatment is the same. Endodontic treatment, over prepping and backfill with amalgam, and root amputation. Root amputation can sometimes be challenging to visualize everything you need to see. Here you can see that there's still some parts of the root left. Appropriately, they should be re-entered and a more self-cleansing area created. A maxillary molar that's going to have a root removed, the treatment's done, and the amalgam is placed prior to the root being amputated. You can see that the palatal root was removed and there's still some sealer left that will resorb over time. An extreme example of hemisection. I don't know that this really contributes to this patient's function. However, remember that this is an example of something that was done many years before implants was a predictable procedure. Again, another extreme tooth, extreme case. You see that there's a lip here and it's contributing to loss of bone in this area. An endodontically involved tooth, there's a lesion of endodontic origin here. There's also vertical bone loss because of periodontal disease. You can see it on recall that we have healing of the endodontic lesion, but this patient also has other issues that need to be attended to. This is a case in where bicuspidization occurred. The endodontic treatment was done, and then the tooth was split in two, basically making the molar into two bicuspids. I really did not agree with this procedure. I felt that the case could have been managed by good oral hygiene in the furcation area. I feel that the restorative procedures just contributed to loss and breakdown of bone around this tooth. Here's a pretty extreme example, again before implants were an option. Both the patient and the dentist wanted to try and retain these teeth as long as possible. Endodontic treatment was performed and the teeth were referred back for restorative care. So the question remains, how much treatment is necessary? Do we need to do an implant in all cases? And I think it comes down to diagnosis. A case where endodontics was felt to be a primary etiology. Here's a 21-year recall. You can see that the tooth is still functional after 21 years. It's in good health. Yes, there is some bone loss here, but the patient is maintaining the tooth in a functional manner. Another tooth that certainly looks like it should be extracted, but again, a 1-year recall, the tooth restored, multiple abutments. This is appropriate treatment, and it highlights that there isn't any need to extract every tooth that appears to have bone loss. Careful diagnosis is necessary. Treatment that involved no endodontics, but just periodontal treatment. Here's a 16-year recall. So these cases can be successful. They can be managed. Not every case has to be extracted and replaced. There are some situations where nothing's going to help, and this is one of those situations. We have horribly extended amalgam. I really don't know what's going on around here. These teeth can't be managed endodontically and they can't be managed periodontally. Very similar to this, an abutment for a long span bridge. There's absolutely nothing we can do to try and save this tooth. So there are situations where nothing's going to help, and it still means that we need to do a careful diagnosis before coming to a decision that includes. This is a very difficult case to manage. It shows a root amputation that was done with a vital tooth. These are difficult to manage for two reasons. One, the patient can develop an irreversible pulpitis following surgery, becomes difficult to isolate, becomes difficult to access and clean and shape and irrigate the canal. Another situation that can happen is after this type of a procedure is done, root amputation of the vital tooth, is that the canals can calcify over time, and when endodontics becomes necessary, it becomes difficult to treat the tooth endodontically.